Am I audible?
Yes.
Okay. So, good morning, good afternoon, good evening, everyone. A warm welcome to all of you joining us online for today's Pediatric Palliative Care Echo Series, Session 5 on Holistic and Specialized Pediatric Palliative Care. It is a pleasure to have you with us. So, we come together to learn and share experiences in providing compassionate care for children and families facing complex health conditions. In today's session, we'll be having an expert discussion with our speaker and followed by a case presentation. And as you all know that everybody knows Anu Savio, and today she's going to be an expert speaker, and she is a palliative care nurse, consultant, educator, and an advocate with extensive experience in pediatric, community, and home based palliative care. She serves as a trustee of Soul Palliative Care Chennai, and it is actively involved in global nursing education and initiatives to strengthen pediatric palliative care, especially in low and middle income countries. Anu has contributed greatly through training, research, and mentorship in both in India and internationally, with a strong focus on pediatric palliative care in nursing and improving equitable access to palliative care services. She is currently pursuing her PhD while continuing to support capacity building and nurse-led leadership initiative globally. Me and my husband was the first people who were motivated by her to do a palliative care in 2014 in Pondicherry. So because of her, we had a training in Pallium India and we continued to uh, do a service from that time onwards. And we are so close to Anu. I'm very happy to listen to her topic today. And over to you, Anu.
Thank you, Dr. Lata, madam, for a wonderful introduction. And as you know, it's like co-learning, getting inspired from each other, and that make us to do more. And then that's what happened. So before, let me just start today's session. Today, the session is about holistic and pediatric, specialized pediatric palliative care. It's a broad topic. Hope my slides are clear. Today's objective is by the end of the session, you will be able to understand about holistic care, what as nurses we could do. Neonatal palliative care, pediatric palliative care in HIV/AIDS, diversional and occupational therapies, home-based pediatric palliative care. Some of the most important patients in palliative care may never speak. A premature baby struggling to breathe in the NICU, a mother trying to soothe pain with a lullaby when the medicines are not enough, a child with severe neurological illness cared for on a mat in a small house. So I am very sure that most of you are dealing with these kind of children in similar settings. So that's why I said in the beginning it's a very broad topic, but let me try to concise. So coming to holistic pediatric palliative care, as we know the dimensions of holistic care: physical, spiritual, social, and psychological. In pediatric palliative care, we are taking care of a child who is sick, who is in need of palliative care, the siblings, the mother and father. Child with some physical problem, maybe mother with spiritual problem, father and mother with emotional problems, sometimes a sibling also with psychological problem, father with again social aspects. So see, just without knowing the diagnosis, just with the terminology that a child needing palliative care comes to us with a family facing problems in all dimension. And again, when you say that we wanted to give holistic pediatric palliative care services, it should be depending upon age, the age appropriateness, the maturity appropriateness, in which milestone the child is. For example, an infant may not be having more, like mainly spiritual problems or psychological problems or social problems. For him or her, the problem may be the physical problem, separation anxiety and things like that. When it comes to a school age child, physical, emotional, a little bit of social problems, maybe because of he couldn't go to regular school, maybe he's kept away from attending the birthday parties or whatever social gatherings. When it is again growing to adolescent, all the dimensions are growing, and that's the main challenge, a difference from adult palliative care. Like for us, every child matters, every situation matters. There is, everything else everything differs from child to child, from patient to patient. A same diagnosis for two different children, same age, same stage, but one belonging to a kind of well-off family, the other child belonging to resource limited or a poor family will have different prognosis depending upon the financial status, the insurance availability, the access to healthcare. So these are all the things that we need to consider when we are planning pediatric palliative care services. So when we want to address all the dimension, we need a multi-professional approach where we need pain specialists, doctors, nurses, social workers, psychologists, dietitian, physiotherapists, chaplain service, volunteers. There are many, 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 many more people in our team, therapist, everybody. The community connectors, community navigators, sometimes the school teachers are also part of pediatric palliative care team to support the children. So my intention is to make you all well clear that when we want to deliver holistic pediatric palliative care services, we need to keep in mind all the dimensions and the multi-professional approach. Also, this is how the services are planned. So the bottom of the pyramid, you have universal services, wherein palliative approach to care incorporated into all services of the children. Core palliative care services, wherein majority of the services of intermediate level expertise, and specialist palliative care services for complex cases in the interdisciplinary teams. Understanding holistic pediatric palliative care, the child and family centered approach, physical, psychological, social, and spiritual dimension, continuum of care from diagnosis to the end of life care and then beyond to bereavement care. And it is always patient centered care. Now, coming to nurses' role in holistic care planning. So, from comprehensive assessment of child and family needs, even in primary care, it starts with early identification of children who require pediatric palliative care need. Once screened and identified, comprehensive assessment, symptom management, psychosocial and spiritual support, advocacy, and coordination of multidisciplinary care. So we are there in almost every aspect of pediatric palliative care, from assessing the need, setting goals of care, prevention and relief from suffering, managing psychosocial issues, culturally sensitive care, effective communication, respite care, end of life care, bereavement support. Everywhere, nurses have a significant, or nurses play a key role in pediatric palliative care. Integrating the holistic approach into our care plans. So here you can see that the family, the child, and the culture pediatric palliative care nursing practice, interdisciplinary pediatric palliative care services, wherein the environment has got a major role with all the facilities and development appropriate and communication. Integrating holistic approach into care plans, individualized care plans. So the child, we have to plan according to what the child is, what is the care needs, what is the setting is, what are the resources available to him, what are the supportive structure that he has. So that is the skill that nurses have by our training to understand the needs and then act accordingly. Family involvement in decision making, culturally sensitive and respectful care, ongoing evaluation and adjustment of care. In the first session, Lilateral has already shown children who benefit from pediatric palliative care. Just for recap, I am showing we have 4 categories as per the classification. Life-threatening conditions for which curative treatment may be feasible but can fall, like in cancer, irreversible organ failure of heart and kidney, conditions where premature death is inevitable, like cystic fibrosis or muscular dystrophy, where the child may require long period of intensive treatment aimed at life prolonging and allowing them to have a near normal quality of life and life, but eventually complications will develop and the child we will lose the child. Progressive conditions without curative treatment options. Treatment is exclusively palliative and may commonly extend over many years, like mucopolysaccharides and Brighton's disease. Irreversible, the category for irreversible but non-progressive conditions causing severe disability, leading to susceptibility to health complications and likelihood of premature death, like in say severe cerebral palsy, multiple disabilities, some congenital problems, some infections or issues happen during the birth which end up in palsy and spasticity, and some childhood injuries too, some traumatic brain injuries, so spinal cord injury with complex care needs, keeping the child at high risk of unpredictable life-threatening events and episodes. As nurses, we knew that what is for a family to have any of these type of children at home. Now coming to, so when we plan holistic palliative care, pediatric palliative care training, palliative care services, we need to plan all the dimensions, all the settings, and then plan the care accordingly. Now coming to specialized pediatric palliative care services. Pediatric palliative care has multiple specialization. Neonatal palliative care, perinatal palliative care for HIV/AIDS, home-based palliative care, grief and bereavement supportive care that will be handled in the future sessions, oncological pediatric palliative care, neuropediatric palliative care. Today I will be touching the base of few the most important aspects like neonatal PC in HIV/AIDS, and home-based PC. First, perinatal and neonatal palliative care. Palliative care can begin during pregnancy when a life-threatening condition is identified, like uh, uh, major neural tube defect, or anencephaly, or renal agenesis, or some complicated problems that we identified during the regular screening or scanning process. And if we know that the baby, the fetus is having a life threatening condition wherein the child, there is very less chance that the child come out healthy, or very less chance that the child can live without support or things like that. So what are the choices, what are the conditions, the discussions has to be required. So on these cases we start to support the mother. We are not thinking that the child will die, but the child requires some kind of long term support. Even in that case we need to plan, prepare the mother, prepare for the pregnancy, prepare for early starting of services. helps a family to prepare emotionally and practically. Perinatal palliative care support informed decision making and care planning. Families can discuss goals of care, birth planning, and comfort focused care options. In that case, if it is well prepared, parents will not go for keeping the child in ICU, on ventilators, on ECMO, on multiple invasive interventions to just push the dates. That they will not plan for it. They will think about it and plan to keep the baby, even if it is for hours together. How to plan that hours, how to keep the memory of that child, how to have the siblings, how to take some photographs to and keep the memory alive. Early involvement improves continuity of care for baby and family. It also provides psychological, social, spiritual support during the uncertainty. All the support, as most of us are mothers, so we know that if there is a small problem, in what all dimensions we get affected. And then imagine these mothers who are going to face the worst thing that they as a person going to face. So that time, how we could support a mother and a family and the siblings, that again, we as nurses have a major role. Neonatal palliative care for newborns with life limiting conditions, focus on comfort, bonding and dignity, pain and symptom control, support for parents during complex decision making and grief, emotional and bereavement support. After learning about neonatal palliative care and palliative care, I think when I had to work in a setting where there was no neonatal palliative care, I felt distress because I knew that these are not the way to treat a mother. These are not the way to do the bonding. But then sometimes, knowing that this is the way forward, and then having kept in a position that we couldn't do much, will, I think, eventually make all of us an advocate for neonatal palliative care. Pediatric palliative care in HIV/AIDS. Palliative care is a vital part of comprehensive care for children living with HIV and AIDS, addressing symptoms such as pain, fatigue, and other distressing effects. In HIV, the main problem is the child has to undergo ART treatment. Father and mother, most of the time, both are infected. So both parents are sick, both parents need continuous treatment. Again, sometimes father may not be there. The child has lost their mother. That trauma is there. Child has lost a sibling. That trauma is there. Sometimes for both father and mother are not there. Child will be in foster care. So imagine the situation of the background or the life of the child. So that is one reason we have kept HIV and AIDS, especially in this module. So we can very well understand now how much support the child require. Major barriers include limited pain management strategies and lack of experience caring for young patient. Family level HIV clustering further complicates children's care as parents are often too affected. So parents will get medicines from one area, child will have to go to another area. So both will be under different clusters. So these are the challenges. Role of nurses: early symptom assessment and relief, growth and nutritional support, play and development support, family centered communication, adherence support to ART, antiretroviral therapy, psychological support for the child and caregivers, home based and community support, school reintegration whenever and wherever possible, dignity, comfort, and quality of life throughout the illness trajectory. So again, all the dimensions, all the support, medical support, financial support may be required, psychological support, emotional support. So again, here again we have a role. So clinicians, educator, a scholar, leader, listener, strategist, and advocate, and many other roles too. Now coming to home-based pediatric palliative care. I have heard from many nurses that Home care, home-based nursing, home care is very easy. It is not easy. Home-based palliative care, more common than inpatient services in many settings, enables families to maintain normalcy while caring for seriously ill children. It is not only creating normalcy. Not all families can have access to services, afford services. So they wait, they don't go to hospitals, they wait till complications arise and then rush to the last moment wherein, there will not be much time left. So there is access problem, there is financial problems. So in ideal setting, we should be able to provide services at their doorsteps, allow to deliver specialized care at home, improving family experience and reducing the cost. So now coming to home-based pediatric palliative care services. Imagine there is a spastic child, a female child, 12, 14-year old, turning puberty. You can imagine what are the fears as a mother she has. She cannot, maybe in rural settings, both parents have to go for work to support the family. Now, parents are having a tension that how to keep the child at home, with whom the child can be kept. And as nurses, we can understand these problems. Again, when we go to home, we can easily pick up when was the last time, or is she getting a proper hair care? Is she getting proper physiotherapy? Is she getting good nutrition? Is she well supported? Is she able to express her pain? So, understanding even without communication is one of the assessment, observing. These are very special skills that a nurse require. And in home-based pediatric palliative care, the advantage is we are able to give comprehensive clinical care at home, be it symptom management, be it early assessment, be it preventive care. Okay, the child should not develop a urinary infection, child should not develop a wet sore. So prophylactically, what we can educate the mother. So those things can be done. Only we can teach things, we can do all these things only when we understand their background. Psychosocial and spiritual support, caregiver empowerment with the available resources, community setting, community connectors, neighborhood networks, how much ever possible, practical assistance, how can the child be well cared, and also sometimes food support, some kind of home-based education support, whatever, some income generating activities can be planned when we can understand the home care setting, and respite and community support with the help of community volunteers. I know that most of you are in settings wherein there is no pediatric palliative care services at all. So this is a open call for all of you. We can plan how to support, how to create that kind of network and services. Home-based palliative care more common than in sorry. Now, next aspect is diversional and occupational therapies. Again, why this is so important for nursing is most of the time in our setting, we will not have an occupational therapist or a diversional therapist, even a physiotherapist in our team because of financial issues. So we should understand that a child who could not play, or child who is not supported in the regular play, is in distress. So we have to ensure that even if a child is receiving pediatric palliative care services, there should be some amount of play, there should be some amount of uh, physically focused interventions. Support normal growth and development and play as much as possible, reduce anxiety, pain, and distress, enhance quality of life. So these are some of the common things that we use in our settings. Encourage play and age appropriate activities. The condition is the child should be familiar with the play materials. It should be safe. It should be culturally appropriate. It should not be at risk. Like we are not going to give beads to infant or no toddlers. So it should be age appropriate according to the maturity. It should help them to build some skills. So it should increase or improve their gross motor activities. Collaboration with occupational therapist if it is if there is a possibility, integrating therapy to daily care, play therapy to daily care, supporting school and social engagement. So rice and beans, we even give disposable water bottles with water for increasing the muscle strength, reducing the spasticity, contractions, and play dough. We don't have play dough, so we make you know with our edible flour. With that we make dough and then we just discard at the end of the day. That is okay. We add food colors and then we make different colors of dough. See, then we let the child to play. For a child, coming to hospital or being sick is sometimes associated with, okay, I cannot play. So when they are happy and playing, the child is happy. So today's take home message: pediatric palliative care is holistic and specialized. Nurses are central to care planning and delivery. Nurses are central and significant, leading, crucial players in this planning and delivery. Integrating services improves outcome for children and families. So conclusion: strengthened understanding of holistic and specialized pediatric palliative care services, emphasize the nurse's role in comprehensive family-centered care, reviewed key principles of palliative care including HIV/AIDS context, highlighted the value of diversion, occupational and home-based care in improving quality of life, and thus we understood that renewed commitment to advocacy, compassion, and coordinated care for children and families. Together we can do better. Pediatric palliative care begins long before the final days of life and far beyond the walls of the hospital. It is in the hands of nurses who notice suffering early, support families through uncertainty, and help create moments of comfort, dignity, play, connection, and meaning because we care. So, after today's session, I just want you to reflect and take an action plan now. Think about your teams and services. What are you currently doing in these three areas? Be it neonatal palliative care, home-based palliative care, HIV/AIDS, or if you're not anywhere in HIV/AIDS, you can keep it as dialysis or oncology or neuro pediatric palliative care services. For the or spastic services, mental retardation clinics, yeah, there are orphanages too. For those who are not currently offering these supports, which inspired you today? Are there any particular areas that you would like to improve or grow in, and why? I have kept all the references in this, and the slides will be coming to you very soon in the WhatsApp group, also in the Echo team. So I think I have finished on time. Let's have a discussion.
Thank you so much, Anu. Very nicely done. Covered everything in a short period. So you have like you started with what is holistic palliative care, like including physical, psychological, social, and visual concerns of not only children and the family, including the siblings. And you also taught us that like explained what is the difference between adult and pediatric palliative care, and what is the need for multidisciplinary team approach in pediatric palliative care, and the like what are the key role of nurses, like assessment, early assessment, and symptom management, psychosocial and spiritual support, advocacy and coordination with the multidisciplinary team approach, and how we can integrate the holistic care to a child, and how we can plan the individualized care plan for children. And you also very nicely explained that how we can integrate in different settings. And then you also like what are the specialty in pediatric palliative care? Like you started from perinatal palliative care, neonatal palliative care, and palliative care for children with HIV and AIDS, and also home-based palliative care. And very nicely you covered that how difficult it is. Like the way you explain that child, you showed the picture of the adolescent girl, like who's going to attain maybe attain menarche, and how she will express her concerns, like how the parents will take care of her. Really, it is very difficult as a mother or a pediatric nurse. And with the whatever the resources available, uh, how these mothers will take care. And so you rightly said that we need to first understand their needs, and then we need to prepare them with the facilities available. And also you like, as we all know that nursing, when the health, like when they started the profession, like it started from maybe from nursing to medicine, doctor, or a nurse, doctor to nurse, I don't know. Okay, so I need to do a search who came first. But whatever it is, but the other specialty like physiotherapy, occupation therapy, nutrition, dietitian, lab technician, OT technician, all the phlebotomist, everything is separated from us. When we didn't do those things, or when we were very busy to do those things, then the new people came into our profession. So I think in a place where we don't have a occupation therapist, a physiotherapist, and we can become a physiotherapist and occupation therapist because we are learning all those things in our curriculum, like active passive exercises and occupation therapy, like fine motor, how to like introduce, how to like develop the fine motor activity, gross motor activity, which we are teaching our students growth and development in each stages, how we need to, how we have to stimulate all those like concerns. So all those development, how we have to integrate, we are teaching to our students. So those things have to come back to us when we are taking care of children in a pediatric palliative care. And also normally also we have to do that for our children. And you last left us with a few questions. So here we are having 135 participants, and we need to fulfill those questions. What is our plan for our children who are suffering with the life limiting and life challenging with the diseases? What is our plan? So, as Sanu has left us with this query, we all have to come out with our solutions. Okay, so now, thank you so much, Anu, for bringing all those informations in a crisp manner. And I hope all the participants have taken up and they will be reflecting this in their work environment. Like somebody mentioned that, like we need to prepare. I like to prepare practically. Yes, as nurses we need to prepare the family practically. And pediatric palliative care is possible everywhere. Let us renew our commitment to advocacy, leadership, and compassionate care for every child and family in need. So are there any particular areas that you would like to improve or grow in? Why? Okay, Anu, you are asking questions to the participants. Yes. So let us discuss, think about it after the case presentation. Okay, now I would like to call upon Mr. Sari Dorji for our case presentation. And without much delay, I would like to invite him for his presentation. And he is a certified intensive care nurse with more than 9 years of experience in the neonatal neonatal intensive care unit in JDWNRH. And he has been providing dedicated and compassionate care to critically ill newborns and their families. Alongside his clinical responsibilities, he is also actively involved in nursing education through continuing medical education sessions, CNES services with the. He's a master trainer in neonatal basic life support and advanced life support programs. He is also committed member of palliative care team supporting neonatal and pediatric palliative care services. And he's currently pursuing fellowship in palliative care to further strengthen his knowledge and skills in holistic patient-centered care. Over to you, Sarin.
Thank you so much, Madam Latha. So, am
I
I
also
audible?
wish to add one line.
Thank you.
It's the third cohort now happening, and every time Lata Madam, Dr. Lata Srikant, and Georgie is so happy to volunteer. All the faculties are volunteers. Volunteer with us and take the sessions, pitch in when and wherever required. And thank you, Georgie.
Yes, thank you so much, Madam Laltha and Madam Anu, and thank you so much, Anu, for your wonderful presentation. So, I will share my slides. Is it visible, ma'am?
It's
Yes, very
visible.
much.
Okay, wait. So, right. Mm. Yes, very good morning, very good evening to all. So thank you, Madam Laltha, for your brief introduction about me. So I will go with our case presentation based on holistic and palliative care in NICU. So key questions for our case presentation. So number one, how can holistic and palliative care principle be applied in ICU for a critically ill unit? What multidisciplinary and family-centered approach support the patient and family during end-of-life care? How can nurses integrate physical, psychological, social, and spiritual care for critically ill infant and their families? So patient details. So this baby is now 28 days old, gender female. So born by C-section at 39 plus 1 weeks of gestational age due to hydrocephalus and dengue walker. So then I've got a score 7 and 9 at birth and 5 minutes respectively. So birth weight 2.9. So currently baby is on CPAP. So mother's history. She is a 22 years old primary and non-consanguineous marriage. And so underlying comorbidities, she has depression disorder and pelvic inflammatory disease, so which was treated in 2024, sorry. Then she also has one spontaneous abortion in 2024. So education till 12 standard and housewife by occupation. Then they have done the first antenatal visit at 7 plus 4 weeks of gestational age. So total they have done 6 times. So there is no antenatal or perinatal complication. So family background. So family background. Father is 27 years old and he is a chronic smoker. So education till 12 standard and he is a tourist guide. So they live in Thimphu, which is our capital city. So at home, they've got a mother and sister, and they are unemployed, and they depend on them for living. Okay, treatment and significant investigation. So soon after the C-section, the baby developed a respiratory distress with a fast breathing that is more than 90 beats per minute, with a severe lower chest retraction, SA score 6 by 10, and then the drop in saturation. Then they immediately admit the baby to an ICU for intensive care management. So primary diagnosis, they kept fetal dandy walker, which is antenatally detected. then other diagnosis is large PDA, ASD, TTNB, jaundice, and then query anophthalmia. So following the investigation that was done to this baby, so USG brain, so which shows a bilateral dilated lateral ventricles, and USG ultrasound of KUB, which shows increased renal ecotexture, and echo shows large PDA and ASD. So infantogram is a normal study. Then for this baby, we have sent a lal path. Unfortunately, we don't have a lal path facilities in Bhutan, so we have sent the sample to India. So to get the report, it takes almost like 1 month. So we are still waiting for the lal path report. So then the blood culture shows the no growth, and septic workup shows no sign of infections. So for respiratory management, for respiratory distress, we have given the CPAP therapy with the setting 5 to 30% flow 6 liter and P 5 centimeter. So in day one, we have kept the baby NPO, and we have started fleet maintenance with the 10% dextrose 60 ml per kg per day, and then initiated feeding on day two. So for weight loss, we have started like incremental feeding plus supplement. Then for PDA and ASD, we have started syrup aldactone and the syrup elastics for 6 days. So then we have planned MRA for this baby, MRA brain for this baby to rule out the brain anomalies. But unfortunately, we failed MRA due to difficult in like intubation. So we have tried a lot, like the neonatologists, they have tried a lot to intubate the baby, but we could not. This is like, even we have used the video laryngoscope, still then we failed. So now we have postponed the MRI. Then counseling and interdepartmental consultation. So counseling, so after admission, so we the pediatric palliative team led by Dr. Tash Shodin, and she's a pediatric team leader. So she is recently done a fellowship in pediatric palliative care in from Hyderabad, and we have done the like counseling to the parents. Then interdepartmental consultation, we have consult to the ophthalmologist for query anophthalmia. We have consult cardiologist for PDA and ASD, and we have consult even like pediatric surgeon for the hydrocephalus. So then the pain and symptoms. So following are the symptoms that are present with this baby. So irritability and respiratory distress, retraction, jaundice, vomiting, pain and discomfort, lethargic, fever on and off. So those are the like symptoms shown by this baby. Then symptom management for like respiratory distress, we have given the CPAP. So then for pain, we have started non-pharmacological and pharmacological pain management. So for non-pharmacological pain management, so we don't have like sucrose. So instead of sucrose, we're using 10% dextrose, and then sometimes we use mother's own milk, and then we used to do the like nesting, and then we're changing the position every 2 hours. So this comes under like non-pharmacological pain management. So then pharmacological pain management, we have started a paracetamol 15 mg per kg per dose. Then nasal care given in every shift. So this baby is on CPAP, so we have given the nasal care in every shift. And then double surface phototherapy for like treatment of jaundice. So then symptom assessment and scale use. So pain scale use, we usually use like neonatal infant pain scale to assess pain, respiratory effort, agitation, and comfort level. So then neonatal skin scoring chart. So since this baby is now 28 days in intensive care units, so this baby has a high risk of developing the pressure sore. So we have used the neonatal skin scoring chart to assess the like pressure sore. The nasal assessment score chart. So this baby is on CPAP for 28 days. So this baby is having like high risk. This baby's already got like nasal injury. So to assess the level of like injury, so we have used the nasal assessment score chart. Then BIP scores are also visual infusion pupillitis score. So usually the baby, those who are born with like congenital anomalies, usually have like they don't have like good like vein. So it's the babies are having like high risk of developing the extravasation and pupillitis. So that's why we have used the VIP score. Then psychological and family concerns. So family stress. So because of prolonged ICU stay and no one to look after the sister and mother at home. So this really add the stress to the family. Then family expressed fear, guilt, and emotional exhaustion since the baby's condition was not good. So still like the baby is admitted in the intensive care unit. So the parents are really exhausted, but they have got strong family networks. So their relatives are helping in terms of financial and emotional support. So definitely they have got financial issues because the father is not been able to work. So he is with the mother, helping mother. So they have got like some financial issues. So the following are the questions that the parents keep on asking to all the health staff. So psychological and family concerns. So number one, we have anxiety about duration of hospital stay. Yes. So they keep on asking these questions. When we will discharge from hospital. So these things are common. So they are asking this question. Then thoughts about the reducing the child's suffering, and will my child inherit or develop this disease? So how can my child be free from machine? And thoughts like, will my child survive? Will the child develop the further complication? Will my child develop the complication in future? So these are like the concerns that were shared by the parents. Then spiritual concerns. So as we are the Buddhism, so we usually like the belief in God. So what they did was the family they performed ritual at home as a part of treatment and culture belief. So then the spiritual practice gave them hope and emotional relief. So then the healthcare provider respected and supported their beliefs. So and then we have involved the hospital lama, so which is called Buddhist master. So we have a Buddhist master which is appointed by government in each hospital. So they they serve as a spiritual counselor, and but sometimes they even do like rituals as a part of treatment to the patient. So then hope and faith is a primary coping mechanism. So nursing issues. So these are the issues that we are facing. So number one, challenging in educating or counseling the parents regarding the disease condition. So since the dental workers are like one of the complex like disease condition, it's quite difficult for the nurses to give the health education to the parents. So these challenges we are facing. Then increase intracranial pressure due to hydrocephalus. So this also increase like we have to do the frequent assessment of tone and reflex. Then we have to measure the OFC daily. Then we have to maintain the head in the neutral position to promote the venous drainage. Then respiratory compromises. So due to the poor neurological control that affect breathing. Then feeding difficulties and nutrition. So failure to thrive. So this baby lack coordinated suckling, swallowing, and breathing. So then this baby is having like high risk of developing choking or aspiration. Then family support and counseling. So that we are doing whenever necessary. So then like challenging in opening the intravenous lines. Then the nasal injury. Yes, this is the main issue we are facing because this baby is on CPAP for 28 days. So we have seen this, the nasal septum are already injured. So sometimes we have seen the like bleeding from the nasal septum. So this really gives the pain and discomfort to the baby. But what we are doing as of now, we used to give the nasal care. We used to like clean the nasal with the anise, then we apply the coconut oil, then we're using the nasal protector. So then, so the other thing is that we are changing the nasal prong to nasal mask every 2 to 3 hours, so that we are following. Then the risk for infection and impaired skin integrity. So longer the hospital stay, high risk for infections and impaired skin integrity. Then communication. What does the patient and family know about disease? So then antenatal counseling to parents was done by gynecologists. So this, when it comes to these parents, so they have already got the antenatal counseling from the gynecologist. So we have not faced much issue while giving the counseling. So because they are already prepared, mentally prepared. Then regular update of baby's condition to the parents every shift. Then transparent and empathetic discussion about the prognosis. So then we have involved the family in decision making in every step. Then psychological, emotional support to the parents were given all the times. Then during her admission, so our neonatology pediatrician and the nurses have explained about the objectives of treatment, that is pain management, management of discomfort, positioning and prevention of pressure sore and infection and feeding issues. That was already explained during the admission. Then the pediatric palliative care team and the Buddhist master were involved in providing emotional and psychological support to the parents. Then collaboration and partnership. So following are the team that were involved in this baby. So number one, we have a neonatology and pediatrician residents and nurses. Then we have our ophthalmologists. Then we have a cardiologist, pediatric surgeon, and we have pediatric palliative team member, and we have a technical team from the laboratory, ultrasonography, and echocardiogram. Goal of care and advanced care planning. So we have an immediate goal of care, that is stabilization or respiratory support. Soon after admission, we have stabilized the respiratory with the help of CPAP, then with stabilization of circulatory, then managing the feeding intolerance, managing pain and discomfort, and the control infection. Then the monitoring of vital sign and organ function. In advanced care planning, we have a family-centered communication. So I provided a clear and honest information in compassionate way, ensure culture sensitivity and respect the parental values and beliefs, involve the parents in treatments and decision making. So these things we have done. So then we have discussed even the potential pathway, so curative approach. So at the beginning, the baby was like treated as a curative approach as babies maintaining saturation in the low CPAP setting. But palliative approach. So then later, so care shifted more towards the palliative than the curative as the baby's condition started worsening. Then family counseling, so updated a baby's condition to the parents. So involve parents in care, decision making, and treatment of baby. So spiritual master were involved in providing counseling. Then issue noted and intervention. So prognosis. So we have already like explained earlier that so parents they've already like got the antenatal counseling and even the after admission of baby in NICU we have given the with the help of neonatology and other department and then with the help of pediatric team we have given the counseling. So finally the parents they accepted and we just give it to the DNR. Then financial stress. So family and social support mobilize. So we have a welfare team in our hospital. So whenever the parents they face a financial issue, so we inform the welfare team, and they will get some financial support. So same like this. So same like those parents. So even these parents they got financial some financial support from the like welfare team. Then parental distress. So for this, we have given this psychological and emotional support all the times. So pain and discomfort. So needs guided pain management were done. Then spiritual needs. Family were allowed or family were given the permission to do the prayers and rituals in the hospital. So then no improvement in baby's condition after intensive care and treatment. So the care shifted to the palliative care. So case summary, so this baby is a term baby, but with 2.9 kg, born by C-section, non-vigorous at birth, and cried after the initial steps of resuscitation. Soon after birth, the baby are presented with the first breathing, severe lower chest retraction, grunting, and decreased oxygen saturation, and was admitted to an ICU and found to have multiple congenital anomalies like including the PDA-ASD, loss at ear, cleft palate. So managed with the CPAP and fleet maintenance. The baby is now 28 days old and remains on CPAP with no significant improvement despite intensive care. So after discussion with the parents, the focus of the care was shifted from the curative treatment to the palliative care. The prognosis was explained to the parents, and the baby is currently receiving the palliative care. So regular counseling is being provided to the parents. So these are the key questions of our case presentation. So role of palliative care in NICU. How can we support this patient and family through holistic and palliative care approach? How can we assist and manage pain and other distressing symptoms? How can we support the exhausted parents? So I think this is the end of my case presentation, and thank you so much.
So, thank you, Dr. Sarin, Mr. Saring Dorji. Like from Manu's first slide, whatever she was talking, all those points were well taken. I think all the participants will agree with me that whatever like physical, psychological, social, financial, spiritual, and all the aspects, including the caregivers and the mother and the sister, all of them were taken care by the multidisciplinary team of his hospital. Really very interesting case you have brought for our discussion. And now like there are many experienced people are there in our team. We encourage people to come up with what else we can do for them. But when we talk about this child, the baby was at the zero, before the 0 hour, prenatally itself was requiring the palliative care because it was diagnosed. They have found out intrauterine itself some abnormality was there for the baby. Okay, so we are come across we are seeing many mothers like if they have a bad obstetrical history, that memories will pass on to the next pregnancy also. So you think of the mother, the first was abortion, and second one is with the baby with the congenital anomaly. Now, how she would be with the next pregnancy? Because I have taken care of many mothers with this type of conditions, and they undergo the lot of like they will be having will I have a normal baby? Whether this baby also I will go for abortion. Like so many queries will come. The memories, all those memories will be carried on to the not only to the mother and to the entire family. So how are we going to help this family? Please come out and help our Saring, who has brought a very good case to us. Please give us some suggestion for him to prepare the family. If you want to talk, you can like uh, you can unmute and talk, or you can put your points in the chat. How can we support the family? What is your suggestion? And I know all of you are experienced. You can come out with some suggestions which will help. He has excellently managed the child and the family. But what else we can suggest for him? Today, when I was coming from pain and palliative care clinic to my ward, I was crossing a OPD where one father was sitting with a baby. Baby was screaming with hunger, and he couldn't know how to control the baby. Baby was 5 months old. Mother went for some dental care, and baby is starving for ultrasound. He couldn't console the baby. So I was when I was entering into the OPD gate itself, the baby, I couldn't tolerate the baby's cry. I ran and I cuddled the baby and I was consoling the baby. Then I did this non-native pacifying with a gauze piece, and because baby was kept starving for ultrasound. So the father was so happy and he was thanking me because baby after some time become calm, and baby was like about to sleep. So the father was so happy and he was thanking me like anything. Like, so what else, like small help we can do for poor in this type of distress? What can be, what is your suggestion for Saring to carry on with this family? All the participants, please suggest him at least few points. Great presentation. Anybody who wants to contribute?
Any suggestions, any doubts, any stories that you want to share? Oh, I have seen pediatric palliative care nurses being called as god of small things. Like they do small things, which has great impact for the children and the family. Um, I am not sure like how many of you have experienced this in your real life. Many a times in our busy schedule, for sometimes, at least sometimes, a hectic schedule, uh, for us they are patients, and for them it's their life. It is their life. It is the few hours before life, it is the few days before. So that matters for them, these small things. I can see Fausti.
Yeah, thank you very much. From the case presented, what will be the most issues in the setting of Rwanda is that the counseling part, most of the time when the mother is a prime gravida, and the family seem to think around what has been wrong from the mother side or the father side. Like they presented that the father is a smoker. They can just link that probably it come from the nicotine from the smoke, or because it is the first time they may think that the mother did something wrong, so the pregnancy didn't end well. And most of the time some culture beliefs which can't be confused through medical expertise or the prognosis of the conditions mostly surround the case, and most of the time impact on the effective communication between the family and the healthcare providers, because they keep believing that something went wrong. So it is not just genetic issues, or and the mother would be challenged about, because it's the first time, will I have the second baby with the same husband? Will the second baby be normal, or he will be sick too? So all those burden the mother mind, and most of the time withdraw her from the positive communication with the caring team. Thank you.
Thank you so much, Fausti. And somebody has written great presentation. It is hard topic to discuss, but parents usually benefit a lot from a small thing. Palliative care team.
Thank you for stay. And I can see one more hands from Joseph. Thank you,
Oh, yes, thank you for giving me the opportunity. Just right from Kenya. I didn't hear spiritual issues being addressed. They must have themselves why. Why was it our family? And where was God? So it is good to have a spiritual assessment and spiritual care given accordingly as the beliefs and spiritual beliefs of the family. Thank you.
Thank you so much for bringing in the spiritual. As I shared in the shared upfront, this is a very broad topic. We can only touch the surface. Spiritual issues alone, emotional, financial, the stigma and barriers are alone very complex, complicated, layered issues or challenges that are put forward. We need to develop culturally sensitive, respectful assessment tools, understand the spiritual needs of father if they are from two religious aspects, spirituality aspects, yes. And let me ask you, in the healthcare team, who is well positioned to assess and address these things when a child comes with needing for pediatric palliative care? I'll put the question again. In a multidisciplinary team, you have seen all the team members. Who is better positioned to understand, to address, to even identify these issues, these challenges, these complex and sensitive areas when a child and family comes for needing pediatric palliative care, whether they are at home, whether they are at hospital. Yes. And yes. Thank you. It is nurses.
I think, madam, someone's already raised their hand, no, ma'am?
Joseph has already given. Anybody else? Thank you, Joseph. Hi,
Another
Ashish, you
thing
are
is on,
unmute. Ashish, we cannot hear you.
So, madam, can I say few things?
yes.
Yes, Georgie.
So, like, when it comes to like these parents, so I think these parents really need counseling, because now, so if now their like main worry is like if they plan the pregnancy in future, so now they're worried about like, so maybe like in future again they may have like the same baby, so they are so much worried. So I think being a healthcare workers and like nurses, so I think we really need to like try to have to change, like, and we have to give the counseling, and we have to like change the thought of parents. So I think we're facing a little bit challenging in this, because now we have to like make the parents assure that in the future, if you are planning for the pregnancy, like definitely you will have a like you may have like a healthy baby, not like this baby. So I think when it comes to this, so we really need like specialized like counseling, no. So this is just my doubt. I feel like that, no.
Actually, this family, mother and the father, both of them may be feeling guilt. They may be having like especially mother may be having a guilt. So how are we going to face this? How are we going to uh, know that she is having a guilt feeling because of me only? First baby, it's I had an abortion. Second one is with the congenital anomaly. Whether I took some food which is harmful to my baby, whether I was exposed to some infection, whether I did not take care myself. Like so many queries mother will have, and father also, because we know that he is a smoker.
Yes, chronic smoker. Yes.
So they both may be having a different kinds of guilt feeling. So we need to explore, and we need to have a family counseling and we need to go for like already genetic testing is going on. And so we need to, after that only we have to, like with the, after the genetic workup only, we have to, with the report only, as a multidisciplinary team, and we need to sit and discuss with the family about the future pregnancy.
Yes, thank you so much.
Anybody else have any other points to, yes, memory making can be done, yes. Any other points anybody wanted to add?
I wanted to add about memory a bit. Every mother, even the child is born, born dead, or she lost the child in first few hours. That is a child for a mother, and that memory will be there till her memory fades, or till the end. So it's so important to have that memory. See, the rest of the life is with that memory, whether it can be haunting, it can be filled with guilt, it can then later, if something that she feels guilty later, so we can help to have that few hours or that few minutes, or how we react or how we give, or something as to preserve that memory as a good memory. These things are never, I will not say good, but not that bad, or reduce the impact. So we could do a lot of things. A small thumb imprints, you do those imprints. Photographs these days, it is very easy. And letting the mother to participate if she is okay. There are very beautiful things that we could do. In our first batch, first cohort, the session was taken by Erin, and there is a beautiful blog by Erin about, as a mother, she has written about how she faced she lost a daughter few years ago, and few hours, so how she has uh, you know uh, traveled, or like took that journey. It's a wonderful blog. I can post it here. So again, we nurses can create a lasting impact in that hours by being present over there, by enabling mother to face that, by our reassurance, by equipping with whatever the mother requires. This is not, something, uh, something, so difficult, but this is so important for that mother. So
Anybody else want to give any? Okay, Anu, no questions. Nobody is raising hand. Can we close? Okay, before going to close
I will
this,
post that blog here.
Okay. So closing remarks, I would like to thank Mr. Sarin for bringing a wonderful case scenario which we discussed, and for it was very meaningful case presentation, and sincere thanks once again to Anu for sharing your valuable expertise and experience with us today. And I also thank Posti and Joseph for bringing uh, more information, and also all the participants who are having a positive feedback on the chat and positive comments about this presentation. And I like to participate. I like to thank all the participants who are actively participating and actively listening. And so with this, we come to the end of this session. We will meet in the next session. Thank you so much for all your presence on this day. Thank you. Thank you, Anu, and thank you, Sarin.